Assalamu alaikum.
Alaikum salam.
Good afternoon, everyone. Today we'll start our academic activity, which will be in 3 sessions. First will be about rheumatic heart disease by Dr. Sarah Labon. Second is anatomy and pathophysiology of aortic valve disease by Dr. Mohammed Babgi. Third, there will be a journal club discussing regroup trial. So let's welcome our consultant who is joining us today, especially Dr. Fatima Abu Al-Anin, consultant cardiologist, King Abdullah Medical City in Mecca, and Dr. Al-Nazir Athman, consultant cardiac surgeon, King Abdullah Medical City in Mecca. Dr. Sarah, are you ready?
Yes, we are ready.
You can start. Go ahead.
Okay, let me just share screen. Is my screen clear for everyone? Hello?
Yes,
clear.
Okay. Sorry. Okay, Assalamu alaikum wa barakatuh. This is Sarah Labon, resident in King Abdullah Medical City, Mecca. Today I'm going to talk about rheumatic heart disease.
Okay. Doctor, can you do the slideshow, please?
Can what?
Slideshow. كبر slide.
Okay. I'm sorry, just a second. How about now?
No, he means start slideshow.
Okay, I started already. It's not.
No,
It's not showing.
The main PowerPoint.
You can start the slideshow, then do the share screen.
Okay. Okay, I will stop share first, then. Okay, how about now?
Yes, great.
واضح دكتورة تفضلي.
تفضلي.
Okay, thank you so much. Okay, starting with my objectives, first we're going to talk about the first phase of presentation. We're going to talk about the acute rheumatic fever, epidemiology, pathogenesis, symptoms, major and minor manifestation, diagnosis, and talking about group A streptococcal infection, prediction, and exceptions. For the second part, we're going to talk about rheumatic heart disease, definition and epidemiology, course of valve lesion, diagnosis, screening, management, and prevention. Okay, acute rheumatic fever. Acute rheumatic fever is an unsuppurative sequela that occur within 1 to 5 weeks, usually 2 to 3 weeks, of group A streptococcal tonsillopharyngitis. It's a disease caused by group A streptococcal, which is acute rheumatic fever, rheumatic heart disease, glomerulonephritis, and other invasive infections. It's estimated to be affect over 33 million people, and it's the leading cause of cardiovascular during the first 5 years of life. Acute rheumatic fever can occur at any age, and most causes occur in children in about 5 to 15 years of age. Streptococcal pharyngitis is the only streptococcal that is clearly associated with acute rheumatic fever, although streptococcal pyoderma appear to be capable of triggering the condition in tropical areas. For the pathogenesis, I would rather to explain it over. For the pathogenesis, the activation of the innate immune system following a group A streptococcal can lead to presentation of the T cell and B cell through the production of immunoglobulin G antibody and activation of the CD4. In some individuals, there's a cross-reactive immune response mediated by the molecular mimicry, which implies the structural similarity between some infectious agent and the human proteins. The cross-reactive response or molecular mimicry between the streptococcal, specifically group A carbohydrate or stereotype specific M protein, and the host heart, brain, joint, or skin can lead to the autoimmune response. Acute rheumatic fever may result from a host genetic predisposition, and it's believed to be highly heritable disease. In this picture, it's actually shown, we said earlier, with the activation of the innate system and with the molecular mimicry attacking the human own tissue, causing the major and minor manifestations. For the carditis, specifically, in human heart, interlesional T cell will react to the meromycin, mycin, and valve-derived proteins, which lead to immunological response. Autoreactive T cell is important in the formation of the Askov nodules in the cardiac valve. In the vascular cell adhesion molecular 1, it is the link between the humoral and the cellular immunity of the valve surface. It's upregulated on the surface of the valve endothelium after binding of the cross-reactive antibodies, leading to adherence of the T cell in the endothelium with infiltration into the valve, resulting in the formation of the granulomatous region, which is the Askov bodies. For the symptoms, there are two primary forms of representation of acute rheumatic fever. 70 to 75% of patients is in the acute febrile illness with joint manifestation and often carditis. It is commonly to be followed by rheumatic heart disease. Less commonly formed with the 25 to 30% is the neurological behavior disorder with Sydenham chorea. Here, joint manifestation actually usually absent, and carditis when present is often subclinical. And this form is an atypical presentation of acute rheumatic fever with a 50% chance to be followed by rheumatic heart disease. Okay, now talking about the major and minor manifestation from the joints criteria. Starting with the minor, we have fever that is usually more than 38.5 orally. However, in low-grade fever, it's common in a high-risk group. Arthalgia with polyarthalgia, elevated acute phase reactant, which are almost always elevated in acute rheumatic fever, except in some patients with isolated chorea or those who are treated with anti-rheumatic drugs. Okay, let's go super quickly over every major manifestation, starting with arthritis. Arthritis is the earliest symptoms representing within 21 days of the infection. It's more common in teenager and young adult. The joint pain typically more prominent than sign of inflammation, and it's almost always transit with the leg joint typically involved first. It's usually overlapped, giving the migrate appearance. And we should always reconsider diagnosis of acute rheumatic fever if the joint symptoms does not respond to the NSAID treatment within 48 hours. In Sydenham chorea, it's actually a neurological disorder consisting of aberrant non-rhythmic involuntary movement that is more marked on one side with a muscular weakness and emotional disturbance that involve the basal ganglia and the cortical structures. It presents from 1 to 2 months after the infection, and it's more common in females. Erythema Marginatum, it's an embryonic rash that is commonly involved in the trunk area, and it's appears early in the acute rheumatic fever. It's also known as erythema annular since the margin of the lesion is usually continuous, make a ring. Subcutaneous nodules is actually small, firm, painless nodule up to 2 centimeters in size. It rarely appears as the only manifestation. It's usually symmetric and located over the bony surface and the extensor areas. Okay, finally talking about the carditis, it's classically considered to be pancreatitis. The predominant manifestation presenting as a valvulitis, especially if the mitral and the aortic valve, it's usually within 3 weeks of infection. Mitral regurgitation is the most typical form of valvulitis in nearly all cases of rheumatic heart disease. The aortic valve involved in approximately 20 to 30% of cases. Tricuspid valve is commonly affected, but frequently subclinical, and pulmonic valve involvement is rare. Pericarditis occur in up to 10% of patients with pain, with presence of pericardial friction rub. It's usually transit and generally resolved without sequela, with cardiac tamponade reported rarely. Subclinical carditis detected only by echocardiography or Doppler constitute for up to 53% of patients. Since valvulitis is generally a prominent manifestation of rheumatic carditis, a diagnosis of rheumatic carditis should be re-evaluated if pericarditis, myocarditis, or conduction abnormalities occur in the absence of valvulitis. Okay, for the diagnosis of carditis, suspected or confirmed acute rheumatic fever or new murmur should undergo echocardiography to determine the valve abnormalities. In all cases, echo must be done to confirm both morphological and pathological features. Here we're going to talk about the morphological features for the mitral valve changes. We can see a mitral valve prolapse, particularly in the anterior leaflet, beading and focal thickening of the leaflet, elongated and chordal rupture, and there should be no feature suggestive of chronic rheumatic heart disease, such as leaflet or chordal thickening, infusion, calcification, and restricted leaflet motion. For the aortic valve changes, it can be manifest as irregular or focal leaflet thickening, coaptation effect, restricted leaflet motion, or leaflet prolapse. And these features of aortic valve involvement are less specific and may share similar features to that of chronic rheumatic heart disease. For the pathological features, in mitral regurg, it should be seen in at least 2 views, jet length more than 2, peak velocity more than 3, and pansystolic jet at least 1 envelope. For the pathological for aortic regurg, also it should be seen in at least 2 views, jet length more than 1, peak velocity more than 3 in diastole, and pan-diastolic jet at least in 1 envelope. Okay, diagnosis of acute rheumatic fever is established on the clinical ground using 2015 Jones criteria, which certified upon whether the patient from a low risk or moderate to high risk group. For the cardiac evaluation, chest X-ray, echocardiography, electrocardiogram are essential to be performed as a part of the initial diagnostic workup. Okay, here we are reviewing the Jones criteria. So the diagnosis of the initial episode of acute rheumatic fever, it can be done when there is a 2 major manifestation or 1 major plus 2 minor. It should be sufficient for the diagnosis of the initial episode of acute rheumatic fever. In patient also with evidence of preceding group A streptococcal infection. In case of recurrent patient with a history of acute rheumatic fever are at least at risk of recurrent episode with the group A streptococcal reinfection, repeated episodes are associated with a greater likelihood of severe cardiac involvement. In this patient, 2 major or 1 major plus 2 minor or 3 minor manifestations are sufficient for the diagnosis of the recurrent acute rheumatic fever. The criteria here are slightly modified for the moderate to high risk group population as follows. The major criteria of arthritis include monoarthritis or polyarthralgia in addition to polyarthritis. Polyarthralgia should only be considered as a major manifestation after exclusion of other causes. The minor criteria of joint involvement are monoarthralgia other than polyarthralgia. And we can see here in the moderate and high risk population, a lower cutoff of the fever as a low grade fever, and lower cutoff of the ESR, but CRP cutoff is unchanged. Okay, for the group A streptococcal infection, we have some exceptions. There are circumstances in which the diagnosis of acute rheumatic fever can be made without a strict adherence to the criteria. If the only manifestation was chorea, this patient should undergo evaluation for carditis with the echo, or if in case of indolent carditis as the only manifestation, patient will come with the medical attention month after acute group A streptococcal infection, and echocardiogram should be performed in this patient to look for evidence of carditis. And to look for the evidence of a group A streptococcal infection, positive throat culture can be done, positive rapid antigen test, or elevated antibody titer with either ASO or ATP can be done. Throat culture are negative in approximately 75% of patients by the time of manifestation, and rapid streptococcal antigen test also commonly negative. So the measurement of antibody titer, the ASO and ATP, is the most used in clinical practice. Here we have a prospective study in children with acute rheumatic fever followed for 2 to 15 years during modern era in Brazil. It was found that 70% of the 258 subjects developed chronic valvular disease and 16 progressed severe aortic and/or mitral disease, which will lead us to the second half of the presentation, rheumatic heart disease. Okay. Rheumatic heart disease is the most common cause of severe sequelae of acute rheumatic fever. It usually occurs 10 to 20 years after the original illness, although it may present earlier after a severe or recurrent episode of acute rheumatic fever. It's the most common cause of acquired valvular disease in the world. Mitral valve is more commonly involved than the aortic valve, and mitral regurg is the most common finding. Valvular damage manifested as murmur later in life occur in approximately 50% of patients who had arteritis during the initial episode of acute rheumatic fever. Clinically detected rheumatic disease is most diagnosed in individuals aged 20 to 15 years of age, with only 2/3 of cases occurring in females. Rheumatic heart disease is by far the most important form of acquired heart disease in children and young adults living in developing countries. It accounts for approximately 50% of all patients with heart failure in endemic countries. The prevalence of rheumatic heart disease has been rising steadily since 1990, reaching 40.5 million up to 2019. Okay. Let's start with the course of valve lesion, starting with the mitral regurgitation. It is the most common early valvular manifestation, and the mechanism of impact during acute rheumatic fever related to the combination of annulitis with annular dilatation, chorditis with a chordal elongation, and valvulitis resulting in a typically anterior mitral leaflet prolapse with and pathological MR. Patient with a chronic MR has a frequently prolonged asymptomatic phase, as the volume load of chronic MR may be well tolerated for several years. Among patients with acute rheumatic carditis, the intensity and time course of the inflammatory process may impact the course of mitral valve disease. This figure presents the theoretical pathway for the various manifestations of rheumatic mitral valve disease. The initial inflammatory response following the first episode of acute rheumatic fever determines the degree and the extent of the structural involvement of the mitral valve apparatus. Severe inflammation of the chordal structure and mitral valve leaflets often lead to severe mitral regurg in the very young age, where moderate inflammation followed by repeat events of acute rheumatic fever more likely to cause mixed mitral valve disease later in life. Isolated mitral stenosis is usually a consequence of milder or a subclinical form of acute rheumatic fever, followed by episode of recurrent carditis. On the right side, we have a chest X-ray from a female known case of mitral regurg, demonstrate a cardiomegaly, the left atrial and left ventricular enlargement, as well as mild pulmonary venous regurgitation compared to the normal X-ray on the left side. Here I have an apical four-chamber view with a color flow Doppler, shows a severe mitral regurgitation during the systole associated with the enlargement of the left ventricle and the left atrium. Okay. Moving on to the mitral stenosis. Rheumatic heart disease is the most common cause of mitral stenosis worldwide. Survival is more than 80% at 10 years for asymptomatic or minimally symptomatic patient with NYHA class 1 or 2. And at the time of the diagnosis, 60% of such patients may not experience any progression of symptoms. Once limiting symptoms with the NYHA class 3 or 4, survival without intervention is worse and has been estimated to be from 0 to 50% over 10 years. Mean survival time falls less than 3 years if severe pulmonary hypertension developed. Mitral stenosis is associated with the highest risk of systemic thromboembolism. The risk increased markedly following the onset of atrial fibrillation and or tiny nodules located along the coaptation portion of the valve leaflet. The leaflet thickened with eventual deposition of fibrin on the cusp and loss of normal valve morphology. Commissural fusion or the fish mouth appearance and shortening are due to recurrent rheumatic fever with repeated valve scarring, but leaflet thickening and calcification appear to be primary due to the stress of chronic turbulent flow through a deformed valve. We have what you said about the commissure fusion or the fish mouth appearance. Okay, this figure will illustrate the progressive of hemodynamic alternation in mitral stenosis. Obstruction to flow in mitral stenosis lead to chronic left atrial pressure overload, which over time will result in pulmonary venous hypertension and left atrial enlargement. Remodeling of the left atrial of the atrium as the substrate of the atrial fibrillation and thromboembolism. Pulmonary venous hypertension passively will increase the pulmonary atrial pressure. Progressively will increase to right ventricular pressure overload, dilatation, and eventually tricuspid regurgitation. Okay, this picture, this is a chest X-ray for a patient with a mitral stenosis with left atrial enlargement causing a straight heart border. There is also cephalization of the pulmonary vessels consisting with the cardiogenic pulmonary edema. Second picture, picture A, we can see a straightened left heart border with a prominent left atrial appendage, and this caused by mitral stenosis. But in picture B, we can see a lateral chest X-ray taking over the patient after swallowing a contrast. We can see a compression of the lower esophagus by the enlargement of the left atrium. Okay, here is another chest X-ray show a widening of the cranial angle in picture A, and elevation of the left atrial bronchus in patient with a mitral stenosis. For the same patient, we have corresponding CT showing illustrate of anatomy underlying the appearance on the chest X-ray that was in picture A. We can see an elevated left bronchus, a prominent left atrial appendage, and enlarged left atrium. Yeah, also we have an we have a apical long axis view showing thickened mitral valve. It has a marked limited mobility and doming with failure open normally during diastole. Moving on to aortic regurgitation. The inability of the aortic valve leaflet to remain closed or cupped during diastole, resulting in left ventricular stroke volume leaking back to the left ventricle. This added volume increases the left ventricular diastolic volume and elevation of the wall stress. The ventricular respond and adapt with the compensatory eccentric hypertrophy. The combination of the left ventricle eccentric hypertrophy with the chamber enlargement will raise the total volume, but the end diastolic pressure remains normal due to an increase in the ventricular compliance. Asymptomatic patient with left ventricular dysfunction, however, develop symptoms of giant and heart failure as a rate of greater than 25% per year. Asymptomatic patient with severe aortic regurg have an expected mortality that exceeded 10% per year. Okay, this is an X-ray. Chest X-ray is not specific for aortic regurg, but in patients with severe aortic regurg, it can show a cardiomegaly due to dilatation of the left ventricle, which enlarge in an inferior and leftward direction. Ascending aorta are often with aortic arch and aortic knob are clearly marked and dilated. Okay, we have here a long axis view of a bicuspid aortic valve showing a dilated left ventricular and thickening of the aortic valve leaflet. Okay, moving on to aortic stenosis. Isolated rheumatic aortic stenosis is very rarely seen. Aortic stenosis are generally progressive gradually over years with a prolonged asymptomatic phase, although the clinical course is variable. Mortality dramatically increases after the development of symptoms, with the average survival without valve replacement after the onset of anginas or syncope or heart failure with only 2 to 3 years. Okay, for the tricuspid and pulmonary, rheumatic tricuspid valve is almost invariably associated with the mitral valve disease. Rheumatic heart disease is a cause of primary tricuspid regurg with a shortened or thickened tricuspid leaflet that are imperfectly sealed during the ventricular systole. It's often associated with a secondary or functional tricuspid regurg occurring with a right heart failure because of dilatation of the right ventricle stretches the tricuspid valve ring. Tricuspid stenosis without a regurgitation is a relatively uncommon condition, and since the diagnosis is difficult to make in physical examination, it's often missed. The tricuspid stenosis actually it can be defined when the valve area when the valve area is less than 1.5, as the normal is 7 centimeter. Then it will result in hemodynamically significant stenosis. For the pulmonary valve, its involvement is very rare in case of rheumatic heart disease. For the diagnosis, generally confirmed by transthoracic echo, which enable assessment of the valve morphology and severity of the valve dysfunction. But transesophageal echo recommended usually to determine the surgical approach, especially in patients whose the transthoracic echo images were clinically limited. Echocardiographs also used to assess the left and right ventricular size function and enable estimation of the pulmonary aortic systolic pressure. Exercise testing with either Doppler echocardiography or cardiac catheterization is important when the resting hemodynamics do not match the clinical symptoms. Here you have the morphological features that it's seen in rheumatic heart disease. In case of mitral valve, anterior mitral valve leaflet will be thickened more than 3, chordal thickening, restricted leaflet motion, and excessive leaflet tip motion during systole. For the aortic valve, we can see irregular or focal thickening, coaptation defect, restrictive leaflet motion, and prolapse. The pathological features are actually the same as the carditis, so we don't have to go through it again. Okay, for the diagnosis, it's either if the patient has no prior history of acute rheumatic fever. In this case, we will need that for diagnosis one of the more following criteria. For the, we need a pathological mitral regurg and at least 2 morphological mitral valve features. Mitral stenosis mean graded more than 4. Pathological aortic regurg and at least 2 morphological features of the rheumatic heart disease of the mitral valve. For individuals less than 35 years old, pathological aortic regurg and at least 2 morphological features of rheumatic heart disease and aortic valve. For individuals less than 20 years old, borderline disease of both the aortic valve and mitral. It would be with the following criteria: if it's at least 2 morphological features of rheumatic heart disease with mitral valve without a pathological mitral regurg or stenosis, pathological mitral regurg, or pathological aortic regurg. But in case of patients with a history of acute rheumatic fever, the diagnosis of rheumatic heart disease differs if there is a typical valvular abnormalities with echo. There are 2 screening approaches that have been applied to rheumatic heart disease, echo and auscultation. Echocardiographic screening show an improved sensitivity over the auscultation to detect the subclinical or missed disease in asymptomatic population. To adjust the duration of the prophylactic antibiotic, we have this table. If the patient is rheumatic fever with carditis and residual heart disease, 10 years or until 40 years of age is needed, whichever is longer for the prophylaxis antibiotic. Rheumatic fever with carditis, but there is no residual heart disease, 10 years or until 21 years of age, whichever is longer. Rheumatic fever without carditis, 5 years or until 21 years of age, and again, whichever is longer. For the management of carditis, the mainstay management of carditis are, which is mainly valvulitis, acute rheumatic fever, are early diagnosis and assessment of the severity using an echo, and management of heart failure and other complications if present. It's suggested not to treat carditis with a glucocorticoid or intravenous immunoglobulin as a grade 2C recommendation, as the available limited quality evidence has not demonstrated improvement in cardiac outcome with this agent. But however, some experts still use glucocorticoid in patients with severe carditis in case of acute cardiac failure. Okay. Now we are finally reaching the discussion about management in each valve abnormality, focusing on the surgical point of view only from the American Heart Association guideline that its latest update in 2020. Starting with the mitral regurgitation. Here we have the stages of mitral regurg. We're not going to go through it, but it's actually it's defined by 4 classes A, B, C, and D, with each stage regarding the anatomy, hemodynamics changes, consequences, and symptoms. Okay, for the mitral regurg surgical management, here we're going to focus on in case of rheumatic heart disease. If it's successful and durable repair is possible, we can go for repair. If it's not, we will go for replacement. We will discuss now the repair versus replacement. There was a study published in 1997 with 350 patients undergo mitral valve surgery for mitral regurg, had preoperative transthoracic echo and transesophageal echo. Repair rather than the replacement was recommended if the following features were present: limited calcification of the leaflet or the annulus, prolapse of less than 1/3 of either leaflet, pure annular dilatation, valvular perforation, and an incomplete papillary muscle rupture. Repair was likely to be less successful and replacement was indicated if extensive calcification or degeneration of leaflet or annulus, prolapse of more than 1/3 of the leaflet tissue, extensive chordal fusion, calcification, or papillary muscle rupture. Here we have the long-term patient survival after mitral valve surgery or chronic mitral regurg. It's better in those with NYHA class 1 or 2 compared to in patients with class 3 and 4 at the time of the surgery. And also the benefit is independent of the type of the procedure performed in case of replacement or repair. Although that the outcome is better with the repair than replacement. Patients with severe left ventricular dysfunction are at increased risk of mortality from mitral valve surgery in terms of preoperative and long-term survival. Mitral valve repair has been preferred to replacement in this setting because of the comparable or better survival figures, despite the frequent, persistent, or recurrent mitral regurg. Valve replacement with excision of the subvalvular apparatus is necessary when there is a severe leaflet disease with subvalvular scarring and calcification. This procedure generally has a negative impact on the left ventricular ejection fraction. If possible, valve replacement with the preservation of the subvalvular apparatus is preferred. This procedure provides a competent valve, preserve the functional component of the subvalvular apparatus, improve the left ventricular ejection fraction geometry and long-term function, and the procedure are better clinical outcome than valve replacement alone. Okay, moving on to the mitral stenosis. Patients with severe mitral stenosis who present with a pulmonary edema without another precipitating cause should be stabilized medically and referred immediately for evaluation for percutaneous valvotomy or surgery. Wilkins score predicts the success of percutaneous pneumomitral valvotomy or valvoplasty in the setting of rheumatic mitral valve stenosis. If the score 8 or less, then a favorable outcome is likely with the percutaneous procedure. Here we have the Wilkins score. It's about 4 factors: the leaflet mobility, valve thickening, subvalvular thickening, valvular calcification, with a maximum score of 6. And if it's 6, and if the score is 8 or less, it would be favorable for the percutaneous intervention. We have the stages of the mitral stenosis. Okay. For the management in rheumatic mitral stenosis, in case of severe mitral stenosis with the mitral valve area less than 1.5 centimeter, if the patient symptomatic with the stage D, with the mitral regurg plus less than 2, then percutaneous balloon procedure will be preferred. If it's severe symptoms, then NYHA score 3 or 4. If the patient is surgical candidate, then mitral valve surgery will be indicated as a class 1. If it's not, then percutaneous procedure will be preferred, but as a class B. In case of asymptomatic patient with a stage C, with the mitral regurg less than +2, then with the pulmonary aortic systolic pressure more than 50, Percutaneous procedure will be the management as a class 2A. If there's a new onset of AFib, then percutaneous as class 2B. In case of progressive mitral stenosis with valve area more than 1.5, with exertional symptoms, stress hemodynamically significant at mitral stenosis, then also it will be a class 2B for the percutaneous balloon. The following clinical features favor mitral valve surgery with the open episiotomy or the valve replacement as the preferred procedure for the mitral stenosis. In case of suboptimal valve anatomy for the percutaneous, such as a severe valve leaflet thickening, calcification, immobility with subvalvular fibrosis, left atrial thrombus with persistent deposition of anticoagulation, concomitant moderate to severe mitral regurgitation, concomitant severe to tricuspid regurgitation. Okay, for the mitral stenosis repair versus replacement, among patients with unfavorable valve morphology who are referred for mitral valve surgery, repair is performed with the open commissurectomy. Replacement is generally considered as the last alternative for the treatment of mitral stenosis because of its higher preoperative mortality and potential for morbidity. However, in symptomatic patients with a severe mitral stenosis in whom neither percutaneous or surgical repair, as we said with the commissurectomy, is possible, valve replacement results in a marked symptomatic improvement and associated with improved long-term survival. Atrial fibrillation in patients with a mitral stenosis are particularly susceptible for development, but at first it will be episodic and paroxysmal and tend to be persistent over time. With the onset of the AFib, there is as much as 30% of reduction in the cardiac output, largely due to a rapid ventricular rate with shortened diastolic filling times. These changes may cause an abrupt increase in the left atrial pressure with a substantial risk of thromboembolism, which may be the first clinical manifestation of rheumatic heart disease in up to 20% of patients. In case of mixed mitral disease, the natural history of concomitant mitral stenosis and regurg is worse than isolated regurg. Only 2/3 of untreated patients with a mixed mitral disease are expected to be alive at 5 years and only 1/3 at years. Patients with mixed mitral valve disease, transmitral mean pressure gradient more than 6 is associated with adverse clinical outcome. Okay, moving on to the aortic regurgitation. Since the rate of progression to symptoms and or systolic dysfunction with a chronic aortic regurg is slow, these patients should be expectantly followed. Patients with a mild to moderate aortic regurg has an excellent survival rate and required no intervention. This is the stages of aortic regurg. Okay. In case of patients severely, there is a severe aortic regurg and whom are symptomatic, it's a class 1 for the replacement. Patient asymptomatic with stage C, but with a left ventricular ejection fraction less than 55, or patients going for other cardiac surgery, mitral valve CABG, or surgery for correction of dilatation or whatever. It's a class 1 indication for the replacement. Patient asymptomatic, but ejection fraction is more than 55. And the left ventricular end systolic dimension is more than 50, left ventricular end, or the index of the left ventricular end systolic dimension more than 25. This patient is for replacement as a class 2A. In case of progressive disease with left ventricular ejection fraction between 55 to 60, with a low surgical risk, replacement will be indicated as a class 2B. Moderate aortic regurg in whom are going for other cardiac surgery, replacement will be indicated as a class 2A. Okay, here starting from the figure on the left side, the patient who perioperatively have a functional class 3 or 4 symptoms have a lower survival rate compared with those with functional class 1 or 2, regardless of either the left ventricular ejection fraction is more than 50, as in the upper picture, or less than 50%. On the right side, patients with a chronic aortic regurg who are in functional class 1 or 2 before surgery have a survival after surgery that is similar to that expected in age and gender matched the normal population. And in contrast, the outcome among the patients who are in functional class 3 or 4 before surgery is worse than in those with functional class 1 or 2. If the left ventricular dysfunction is present for less than 14 months, corrective surgery is more likely to reserve the volume overload status and allow recovery of the ventricle. But in more prolonged left ventricular dysfunction, particularly in those associated with the congestive symptoms, it's usually predictive of a poor left ventricular response. However, aortic valve surgery is still beneficial in patients with prolonged left ventricular dysfunction, where the response may be suboptimal with a persistent left ventricular enlargement and low ejection fraction. But with the reduction of the regurgitation volume is followed by a reduction in the left ventricular filling pressure, and that will decrease the congestive symptoms. Okay, repair versus replacement in the aortic regurg. Most patients with the aortic regurg require aortic replacement, but repair is an option for some patients. Aortic repair has the major advantage compared to replacement of a low thromboembolic risk, which avoid the need of chronic anticoagulant, preservation of near normal aortic valve orifice, and the potential for a complicated reoperation. The main disadvantage are a high rate of reoperation after about 15% at 10 years, and less widespread surgical experience. But valve repair has more common being performed on young patients than an older patient. Okay, moving on to aortic stenosis. Symptomatic severe aortic stenosis is an indication of aortic valve replacement, and surgery associated with a marked reduction in the symptoms and mortality. For patients with symptomatic rheumatic aortic stenosis who do not have a concomitant indication for mitral or other valve surgery, transcatheter aortic valve is an option. Palliative care is recommended for patients with severe symptomatic aortic stenosis who are not candidate for valve replacement. Here we have the stages of aortic stenosis. Okay. For patients with symptomatic aortic stenosis that is severe with stage D1, these patients are for replacement with either surgical replacement or TAVI as a class 1 indication. In patient with aortic valve area less than 1 with ejection fraction less than 50%, if the patient is severe with stage D2 or severe aortic stenosis with stage D3, they are indicated for replacement, also either with surgical replacement or TAVI as a class 1. And in case of patients with aortic stenosis but whom are asymptomatic as a stage C, but with left ventricular ejection fraction less than 50%, or going for other cardiac surgery, in this patient also replacement is indicated as a class 1. Here we have, because we are done with the indication of aortic valve replacement, but now we are going to do a risk assessment for the patient who are indicated for replacement. If they are high surgical risk with a life expectancy more than 1 year, then we get to valve and vascular anatomy assessment if they are suitable for the transfemoral TAVI or not. If yes, we're going to go for TAVI. If no, we're going to go for palliative care. But if the life expectancy is less than 1 year, then we're going to go for the palliative care. In case of risk assessment was estimated not to be a high risk, then we are gonna do assessment for the anticoagulation if there is any contraindication or it cannot be managed or patient is not desired to take the anticoagulant for the rest of his life. If anticoagulation is okay, then we're gonna go for the patient age. If less than 50 years or from if they're less than 50, we're gonna go for the mechanical as a class 2A. If from 50 to 65 years old, then we can give the option for either mechanical or bioprosthetic. More than 65, it would be preferred as a bioprosthetic valve with the class 2A. Or if the patient has the contraindication for the anticoagulation, then bioprosthetic will be as a class 1 indication for the replacement. In case of mixed aortic disease, combined aortic regurgitation and stenosis produces a variable clinical picture depending on whether regurgitation or stenosis is the dominant or whether both are equally significant. Therapy is dictated by close supervision with annual checkup every 6 to 12 months by clinical examination for development of symptoms and echo. For the progression of the valve disease and evidence of the left ventricular dysfunction. Aortic replacement will be indicated if the symptoms develop and or there is a functional deterioration of the left ventricle. Indication of aortic valve replacement in patients with combined aortic stenosis and regurg is a peak transvalvular jet velocity more than 4, which is the same indication for the patient with severe isolated aortic stenosis. Okay, finally, for the tricuspid valve. Tricuspid regurg is often combined with rheumatic mitral valve disease and often progress after mitral valve surgery. For patients with tricuspid regurg and mitral regurg undergoing surgery for correction of mitral valve disease, tricuspid valve annuloplasty is indicated. Annuloplasty is indicated if tricuspid regurg is severe or if moderate tricuspid regurg is accompanied by dilated tricuspid annulus. Tricuspid stenosis, which is uncommon, the surgical correction of the stenosis is indicated in patients whose valve is not suitable for the balloon valvotomy technique. Here are the stages of the tricuspid regurg. Okay. In severe tricuspid regurg with a stage C or D, and the patient at the time of the left-sided valve surgery, a replacement or tricuspid surgery in general will be as a class 1. Patient with right side heart failure with a stage D tricuspid regurg, tricuspid valve surgery will be indicated as a class 2A, or in case of secondary regurg with annular dilatation, but there is no pulmonary aortic pressure or left-sided disease, also a class 2A. Patient with a prior left-sided valve surgery with the absence of severe pulmonary hypertension or right ventricular diastolic dysfunction, tricuspid valve surgery will be indicated as a class 2B, and in patient with asymptomatic stage with the primary tricuspid regurg with progression of right ventricular dilatation and systolic dysfunction, tricuspid valve surgery will be indicated as a class 2B. And with patient with stage B, but there is a progressive tricuspid regurg and he is at the time of the left-sided valve surgery with annular dilatation more than 4, tricuspid valve surgery will be indicated as a class 2A. Okay, finally, for the tricuspid stenosis, intervention for tricuspid stenosis as valve surgery, repair, or replacement or percutaneous balloon is generally reserved for the symptomatic patient with a severe tricuspid stenosis. Choice is made between the valve surgery and balloon based upon the consideration for the surgical risk, the presence of the regurg, and the risk of worsening regurgitation with the valvotomy and the operator experience. The intervention will be as a class 1 for the tricuspid valve surgery will be recommended for patients with severe tricuspid stenosis at the time of the operation of the left-sided valve disease, or tricuspid valve surgery will be recommended for patients with isolated symptomatic severe tricuspid stenosis. Class 2B percutaneous balloon tricuspid commissurectomy might be considered in patients with isolated symptomatic severe tricuspid stenosis without accompanying of tricuspid regurg. Okay, for the prevention of rheumatic heart disease, we have primary and secondary prevention. The primary prevention of the initial development of acute rheumatic fever, it involves the diagnosis of and the antibiotic treatment of group A streptococcal infection. For the secondary prevention of recurrent acute rheumatic fever with a continuous antibiotic prophylaxis is recommended as it can trigger group A streptococcal infection even in case of asymptomatic. There's evidence that secondary prophylaxis with the penicillin reduced the streptococcal infection, recurrent attack of acute rheumatic fever, and frequency and duration of the hospitalization in patients with acute rheumatic fever and rheumatic heart disease. Also, annual influenza vaccination and dental hygiene with the annual checkup are recommended. Okay, thank you so much. This ends my presentation.
Thank you, Dr. Sarah. That is a good enhancement presentation. Any question? Anyone has any question? Dr. Fatma, if you have any comment about the presentation, you want to add some comments.
Thank you, Dr. Sarah, and thank you all the audience for the invitation, and special thank you for Dr. Sarah for the excellent presentation. I would just like to add that take in account that if there's any discrepancy between your patient's symptom and the echo finding, please remember, as Dr. Sarah said, to do the stress echo. Many patients we have that have severe symptoms of shortness of breath, while the echo shows only mild to moderate mitral stenosis. On stress echo, you find that the diastolic gradient has significantly increased, and so the patient was sent for surgery or balloon valvuloplasty according to the Wilkins score. Also take in account that there's no guidelines, no definite guidelines for cases with multivalvular disease. So a patient with mitral regurg and aortic regurg, or as we say, like mitral stenosis and mitral regurgitation, there's no definite guidelines for these patients. So it's really important to take consensus and close observation and close follow-up for your patients. Lastly, the importance of early our intervention in a timely manner, as Dr. Sarah showed in her graphs for mitral regurg and aortic regurg, even if it's according to the guidelines, it's not indicated now, but it's important to do it as early as in a timely manner, because it really affects the patient outcome, his quality of life under long standing. And again, thank you so much for the invitation, and thank you, Dr. Sarah, for the excellent presentation.
Thank you so much, Dr.
Thank you, Dr. Fatma. Any question from the audience? Okay, so we'll take a break now and we'll come back at 14:10. اوكي محمد. دكتور محمد.
يس. السلام عليكم.
وعليكم السلام. يلا go ahead start.
طيب, السلام عليكم everybody. First of all, I would like to thank Dr. Nadir for being here today with us, and we are honored and happy to hear his input. And Dr. Nadir, you are free just to have you or give us your input at any time during my presentation. And for the audience, please interrupt me anytime if you have any comment or question. So today we're gonna speak in this session about the anatomy and pathophysiology of the aortic valve. The content of the presentation will be embryological development, anatomical review of the aortic valve, some histological aspect with regard to the valve composition, then aortic stenosis, pathophysiology and etiology, aortic regurg, and then as a separate entity, the bicuspid aortic valve. Embryologically, during the development of the primary heart tube at the bulbus cordis, the mid portion of the bulbus cordis, there is the conus cordis, which is developed later on to the outflow tract of the right and left ventricle, and the distal portion, which is the truncus arteriosus, developing into the aorta and the pulmonary artery. And within the 5th to 7th week of embryological development, there will be two opposing swellings at the appearing at the level of the conus and truncus arteriosus. With these ridges growing toward each other, and fusion will form the aorticopulmonary septum that's dividing the RV and the LV outflow tract and the right, the pulmonary and pulmonary trunk and the ascending aorta. Once that aorticopulmonary septum is complete, an aortic valve will begin to develop from free swelling of subendocardial tissue. Two swelling will be arising from the fused truncal ridges to develop the right and the left aortic valve leaflet, and the third swelling will be developed into the posterior leaflet. And eventually these swellings will be hollowed and reshaped to form the three thin-walled cusp of the fully developed aortic valve. This diagram just showing the what we just spoke about the embryological development, and then eventually the three or tri-leaflet valve that's been developed. So on the anatomical aspect, the aortic valve is located at the terminal portion of the LVOT, separating it from the aorta, and it's composed of three semilunar leaflets projecting into the ascending aorta. And these leaflets attached across the ventricular arterial junction in a curvilinear fashion, starting from the sinotubular junction, descending down to the ventricular arterial and arterial junction, and back again to the sinotubular junction. And each leaflet has an attachment, therefore, to the aorta and to the left ventricle because of its semilunar shape. And the space between the free edges of these leaflets and the point of attachment to the aorta comprises the outbulging, or what's called the sinuses of Valsalva, from which the coronary artery will arise from the left sinus of Valsalva and the right sinus of Valsalva. And usually the coronary artery will arise from the upper part of the respective sinuses, with the left coronary artery will be a little bit higher than the right coronary artery. Centrally, along the line coaptation where the leaflet meets, there will be a thickened nodule called the nodule of Arantes. And on either side of this nodule, there will be a thin crescent-shaped portion, which is called the linula. And this part of the linula does not play a role in separating the blood, the aortic blood from the ventricular blood. So in some patients, some fenestration or small holes less than 2 millimeters might be present at this linear tissue, and it's functionally not significant and will not affect the hemodynamic. But any fenestration or holes that will result beneath this part of the leaflet, for sure it will be hemodynamically significant, that will, and it will cause significant aortic regurg, such in case of effective endocarditis. The leaflets are separated from one another at the aorta by the commissures between each leaflet, and these commissures named the adjacent leaflet, like right and left leaflet commissure, and the right and posterior or non-coronary commissure, and the left and non-coronary commissure. And beneath these commissure are important anatomical landmarks. And it's important to know these anatomical structure, because it's important when doing a repair or replacement, when taking a suture, and it has an implication in the disease process and explaining why some patients will present with some complication of the disease. So the area adjacent to the left and posterior commissure, or left non-coronary commissure, is the fibrous continuity between the aorta and the mitral valve, which is called the aortomitral curtain. And it's important landmark for root enlargement, posterior root enlargement. While the posterior leaflet attachment is directly above the posterior diverticulum of the LVOT and opposing the right atrial wall. On the right and posterior commissure, beneath that anatomical point, positioned as the penetrating AV bundles, as well as the membrane septum. That's why when taking a stitch at that area, avoid taking deep stitches to avoid causing plaque, as well as if the patient with heavily calcific valve, the calcification might extend to that area and cause conduction abnormalities, or in case of infective endocarditis as well. The right and left commissures opposes the posterior commissure of the pulmonary valve, and the associated cusp, the right and left aortic cusp opposing the right ventricular infundibulum. And this anatomical correlation important for a patient to undergo the anterior root enlargement, the cono procedure, because opening this area will open to the RV infundibulum, but will not affect the aortic valve, because the aortic valve insertion is at different level than the aortic valve insertion, although they are opposing to each other. The only part of the coronary sinuses that is not related to a cardiac chamber, and it's directly related to the pericardium, is the lateral part of the left coronary sinus. These images showing what we just said, the image on the left side showing the central location of the aortic valve with its relation to other structures. Sorry, I cannot use my pointer. I don't know if you can see it or not. Anyway, if we can look between at the level of the left and posterior commissure, the aortomitral continuity, and the area where the AV bundle are located between the non-coronary and the right coronary and the right commissure with other relation. With regard to the similar attachment, we can notice here the image on the right, lower right, the attachment of the commissure. It's starting from the sinotubular junction and descend down to below the anatomical landmark or the anatomical ring to the to have some attachment to the ventricular outflow, and then this ascend again to the sinotubular junction. And that being said, will define why the aortic valve does not have a true annulus because of its similar attachment. And instead, the aortic valve is attached to a hollow cylinder or a cuff of tissue connecting the left ventricular chamber and the proximal aorta. And the distal part, as we said, is attached to the sinotubular junction, while the proximal part is attached to landmark, the hemodynamic, what's called the hemodynamic ventricular arterial junction, and the anatomical ventricular arterial junction. And here is an explanation of these two landmarks. The image on the right with the black dots is defining the anatomical ventricular arterial junction, in which is the area between the proximal part of the aorta and the LVOT, while the dots, the blue dots below that is the hemodynamic ventricular arterial junction, which is the area of attachment of the leaflet to the distal part of the LVOT. This is another image showing the same anatomical attachment of the leaflet to the sinotubular junction at the distal part and proximally to the anatomical and the hemodynamic ventricular arterial junction. On the histological level, valve leaflets consist of 3 layers of endothelium with different density of connective tissue and composition. And if we look to the outer layer of the leaflet and the outer layer of the aorta and the ventricular endothelium at each side, there will be no clear demarcation of the leaflet, and it corresponds to the aortic and ventricular wall. And the leaflet of the endothelial cell is forming a continuum with the aortic and ventricular endothelium in each respective side of the valve. And beneath the endothelium is the extension of the intima of the aorta and the ventricular endocardium, and it's termed the arterialis and ventricularis. And it's shown here in this image, which is the continuum, and the ventricular aspect will be the ventricularis, and the arterial aspect will be the intima of the aorta, which is called the arterialis. Beneath this layer is the lamina fibrosa, and it's heavily dense collagen layer composition, and it's arranged in a circumferential pattern. That's giving the leaflet its strength, and it's important for appearing the stress during diastolic pressure. The third and middle layer, which is the spongiosa, and it's a loose connective tissue layer consisting of water and glycosaminoglycan. And it has negligible strength, but it accommodates the movement between layers during the cardiac cycle and absorbing the shock during the closure of the valve. Any comments so far? With regard to aortic stenosis, it is defined as an incomplete opening of the aortic valve, limiting the forward blood flow during the systole. And it is the most prevalent valvular heart disease in adults, with around 2% prevalence among patients older than 65 of age. And 29% of people have some age-related aortic valve sclerosis without hemodynamically affecting stenosis. The aortic stenosis is commonly more common among men than women, and it's increased with the increasing age. and it's with a prevalence of about 1.3% in patient age group 65 to 75, and rose to 4% in those aged more than 85 years. The commonest cause for aortic stenosis are either the acquired degenerative disease or rheumatic heart disease and Bicuspid aortic valve in younger age population, and we'll speak about that in separate. The acquired degenerative stenosis is the most common aortic stenosis in the developed world, and mainly affecting older population more than 70 years of age. And the pathophysiological process of this is the progressive calcification and deposition of calcium phosphate that mainly occurs at the level of the flexion line at the base of the leaflet. And that deposition will extend to the adjacent aortic annulus and may also involve the sinuses of Valsalva and the ascending aorta. That will lead to restriction and immobilization of the cusp with a restricted movement and opening. And usually the deposition of calcium will be on the arterial or the aortic aspect, and the ventricular aspect will be smooth and spared of any calcification. And usually it's a result of years of mechanical stress. But it's not only the stress. That stress will lead to some inflammatory process with accumulation of lipid and upregulation of the angiotensin enzyme activity that lead to macrophage and inflammatory cell infiltration and a process of fibrosis and calcification, which is similar somehow to atherosclerosis process. For that reason, the risk factors for developing the calcific aortic stenosis are considered similar to risk factor for atherosclerosis, namely the high LDL, smoking, diabetes, and hypertension. And for that reason, the use of statin therapy to minimize the risk of aortic stenosis has been studied with no much significant results. The second etiology is the rheumatic aortic stenosis, and it's least common in the developed world to have a rheumatic aortic stenosis in adults. But the characteristic feature of this is a diffuse fibrous thickening with fusion of the leaflet, which is not present in case of degenerative calcification of aortic valve. Usually there will be no much fusion of the commissures, but it's quite evident in case of rheumatic stenosis. And early in the disease process, there will be some sort of tissue edema and lymphatic infiltration that later will lead to thickening, commissure fusion, and scarred leaflet with restricted movement. The hemodynamic effect of this stenosis will depend on how significant the stenosis is and how compliant the ventricle to these hemodynamic changes. So usually the stenosis and calcification is a slow process and will progress slowly over time. And patient for years will be asymptomatic. And there will be no hemodynamic effect until the valve area reach a critical or hemodynamic significant area of around 1.5 to 2 centimeters square. So once the stenosis reaches such a narrow area, hemodynamic affections start with obstruction to the LVOT and development of increase in the left ventricular pressure with increase in the left ventricular ejection time. All these will result in a pressure gradient across the aortic valve that might reach to up to 100 millimeter mercury. And in order to overcome such a high pressure, the LV has to produce a pressure of around 200 to expel blood out of the left ventricle. This will result in a pressure-loaded stress on the heart, and the heart will adapt to this by increasing the thickness of the myocardium, which results in left ventricular hypertrophy. The hypertrophies heart and become with time less compliant, and the left ventricular end diastolic pressure will increase without the dilatation of the chamber, and this will lead to diastolic dysfunction and diastolic heart failure. And the adverse consequence of this adaptive response will result in an oxygen and supply-demand mismatch in the following manner. The increasing the thickness of the left ventricle with increasing the systolic pressure, as well as the prolongation of the ejection time, all of which will increase the workload in the heart that will increase the demand. On the other hand, this increasing diastolic pressure will decrease the coronary blood flow by increasing the endocardial compression to the coronary arteries, and the prolongation of the ejection time will minimize the diastolic time for which the diastolic coronary blood flow will be minimized, and both of which will decrease the coronary blood flow and decrease the oxygen supply with a resultant myocardial ischemia. And once severe left ventricular hypertrophy once patient has aortic valve replacement, the left ventricular hypertrophy will not be completely reversed in severe cases. And there are some evidence about using the ACE inhibitor for improving the myocardial remodeling, as it was evident that myocardial hypertrophy in patients with aortic stenosis is being characterized by increased gene expression of the collagen and activation of renin angiotensin enzyme. With time, without aortic valve replacement or intervention, the left ventricular adaptive mechanism will fail, and the liver will decompensate and will result in dilated cardiomyopathy and heart failure. And to assess the severity of aortic stenosis, there are different parameters that can be assessed either by echocardiography or cardiac catheterization. The important parameters are the orifice area or the effective orifice area, the mean pressure gradient, and the peak jet velocity, and most of which are being assisted by echocardiography. Importantly, the orifice area using the continuity equation, but sometimes in case of inconsistent result, cardiac catheterization might be used utilizing the Garland formula to assess the orifice area and measuring the LV, EDB, and the aortic pressure to assess the pressure gradient. And the valve area less than 1 centimeter are considered the severe aortic stenosis. And this is the classification of aortic stenosis, with mild aortic stenosis considered of an area of more than 1.5, and severe aortic stenosis with area of less than 1, or a aortic valve area index less than 0.6, and pressure gradient more than 40, or peak velocity more than 4 meters per second. The signs and symptoms of aortic stenosis, there are 3 cardinal symptoms for aortic stenosis, which are the angina pectoris, syncope, and symptoms of congestive heart failure like dyspnea, orthopnea, and PND. And as we said, the progression of disease is slow, and most of patients will have long period of latency, and in which there will be no much symptoms. And at this period, the sudden death rate is only around 1%. But once the patient develops one of the cardinal symptoms, the mortality rate will be much higher, with a mortality, 50% mortality within 5 years for patients who develop angina, and that decreased to 2 years for those who had symptoms of heart failure. Other symptoms associated with aortic stenosis like fatigue, decreased exercise intolerance, and that's mainly due to diastolic dysfunction, dyspnea on exertion, gastrointestinal bleeding secondary to angiodysplasia, and that's mainly due to the traumatic effect of the narrowed valve on the platelet and platelet activation, as well as some patients might have symptoms of atrial fibrillation and pulmonary hypertension, which is the late symptoms. Signs of aortic stenosis, the classical signs is the systolic crescendo decrescendo murmur that's best heard at the aortic area, and also a delayed second heart sound due to delayed or increased systolic time, and sometimes might have a reversed second heart sound. Pulsus parvus tardus, which is a slow rising small pulse, and the sustained apical thrust or heave, and this usually heard or felt at the later stage when the heart becomes to dilate. Assessment of patients with aortic stenosis, usually with a routine assessment tool. The ECG is not specific, but might show some evidence of LVH, of QRS complex or SCT abnormalities. Conduction abnormalities, as we said, either result from septal trauma, damaging to the conduction fiber, or if there is extension of calcification, or in case of endocarditis, if there's extension of the infection to the fiber septum and the involving the conduction pathway. Chest X-ray, most of the time within normal limits, but measured in patients with hemodynamically compensated aortic stenosis. The important tool for assessment is the echo, and echocardiography is used to define the etiology of aortic stenosis, assess the severity of the aortic stenosis, coexisting of other valvular abnormalities, as well as evaluation and assessment of cardiac chamber, most important, the left ventricle, and assessing the systolic and diastolic, as diastolic failure is associated with higher mortality. And these are the parameters to be assessed, as we spoke earlier. In addition to routine echo, sometimes a stress echo might be needed, specifically in patients with low flow, low gradient aortic stenosis, in which valve area might be significant, but there is low pressure gradient due to low ejection fraction. Cardiac catheterization, although it's the gold standard for measuring the transvalvular gradient, it's not routinely used, and it may only be needed in cases of non-invasive tests are inconclusive, or there is a discrepancy between the invasive, non-invasive, and the clinical finding. In addition to calculating the aortic valve area, cardiac catheterization might be important in assessing in doing the preoperative assessment for patients with high risk for coronary artery disease, to assess the coronary anatomy and if patient might need a CABG in addition to aortic valve surgery. Cardiac CT is the only non-invasive modality to assess the amount of calcification, and it has shown accuracy, high accuracy, and reproducibility to quantify aortic valve calcification and the progression, as well as estimating the aortic valve area by the planimetry method. The importance of cardiac CT in case of aortic stenosis also is evident in cases of patients going for TAVI, in measuring the valve annulus, the leaflet length, as well as the annular to coronary ostial distance, which guide the selection of appropriate size for TAVI or the valve. Any comment from your side, Dr. Nadir, with regard to first part of aortic stenosis?
You are doing great, Muhammad. Thank you very much. We'll comment later at the end. Sure.
Okay. The second common pathology of aortic valve, which is the aortic regurgitation, and it's defined as a reflux of blood from the aorta into the left ventricle due to a failure of coaptation at the diastolic phase. And usually the aortic regurg is classified into two etiology. Either the primary disease is affecting the aortic leaflet, or the primary disease is affecting the aortic root, with different causes for each of these group. For the disease that affecting the leaflet, most commonly the leaflet calcific degeneration. As I said, most of the time the calcification will lead to restricted movement, but with extensive calcification and restriction, there will be some shrinkage of the leaflet that will lead to failure of optimum coaptation, myxomatous degeneration, endocarditis, and endocarditis might lead to restriction and failure of coaptation, or sometimes might be due to perforation, which even in case of optimum coaptation, there will be some holes in the basal aspect of the leaflet that will lead to significant valvular regurgitation, rheumatic heart disease, as well as bicuspid aortic valve. Although bicuspid aortic valve most of the time will cause stenosis, some patients will have isolated regurg or even mixed pathology. The primary root disease causes include aortic dissection, trauma, systemic hypertension, chronic systemic hypertension, otitis like syphilis, virus syndromes, systemic arthritis like giant cell arthritis or Takayasu, connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, and other connective tissue disease, all of which will lead to aortic root dilation, and that will pull the leaflet which is attached to that root away from each other and will lead to failure of optimum coaptation. And the pathophysiology of aortic regurg is different from those with acute aortic regurg than those with chronic aortic regurg, and this is mainly due to the adaptive mechanism that's been there for chronic patient with aortic regurg, and it's absent in case of an acute aortic regurg. And it's defined as a significant incompetence of a sudden onset across the previous incompetent valve, in which the blood will return to the ventricle and will cause a sudden increase in the LVED volume and reduce the effective forward stroke volume. The increase in the end-diastolic volume will lead to just minimal increase in the will not increase that much because the heart does not have time to dilate and accommodate a larger volume. This will lead to a rapid increase in the end-diastolic pressure, and this will lead to higher left atrial pressure and will lead to pulmonary hypertension and pulmonary edema. In order to compensate for such an abnormal physiology, the heart will have to produce two compensatory mechanisms. First thing, increase the contractility attributable to the Frank-Starling law, and the other is to increase the heart rate, both of which will increase the forward stroke volume and minimizing the end-diastolic pressure. On the other hand, chronic aortic regurgitation is a slow process, and that gives time to the LV to adapt to the increased end-diastolic volume and end-diastolic pressure and the wall stress. And this will signal an increase in the myocyte length in addition to addition of more sarcomeres in a pattern of eccentric hypertrophy. And the enlargement of the chamber will increase the total stroke volume and the maintained forward stroke volume. The increased stroke volume, along with slightly elevated end-diastolic pressure, is the cause of wide pulse pressure, which is the principal physiological process for many of the signs of aortic regurg. The factors that play a role in increasing the forward stroke volume in such patients are decreasing the afterload, and that's why it's one of the important management strategies is to decrease the afterload to increase the forward stroke volume, and the other thing is to increase the heart rate. As the aortic regurg progress, the hypertrophic response will become inadequate, and any further increase in the afterload will result in afterload mismatch and resulting in LV failure with reduced ejection fraction. In addition to this, myocardial ischemia also will result from both the decreased coronary artery perfusion as well as increase the myocardial oxygen demand, which will further impair the left ventricular function. The signs and symptoms of aortic regurg, as we said, acute aortic regurg, the heart does not have time to accommodate and adapt. And usually such patients will present with sudden collapse with symptoms of heart failure and pulmonary edema. And also patients will present with ischemic chest pain. Patients with chronic aortic regurg, they will have gradual development of symptoms, mainly symptoms of heart failure with exertional dyspnea, orthopnea, and PND. Other symptoms might be related to rarely, but sometimes present, like palpitation with emotional changes or exercise, angina pectoris, or atypical chest pain syndrome. The classical finding of aortic regurg is an immediate early diastolic decrease in murmur. Other findings mainly related to wide pulse pressure, as we said earlier, and there are many signs for aortic regurg, commonly the water Hamel pulse or the Corrigan pulse. Some other sign like demostate sign, Wink pulses, Tropo sign, all of which are related to the same physiological change. Other findings are associated with congestive heart failure, such as pulmonary edema, rales, and crepitation, or a finding of S3 sound in cardiac auscultation. For assessment of such patient, the ECG will show evidence of left axis deviation, and usually there will be evident Q waves in the anterolateral leads, which is indicative of diastolic volume overload. Most of the time in early and decompensated and well-compensated patients, there will be the X-ray will be non-significant, but patients with congestive heart failure and pulmonary edema, there will be some evidence of dilated heart or evidence of pulmonary edema with civilization of the pulmonary vasculature. Echocardiography for all valve lesions are the gold standard and the most useful diagnostic modality for diagnosis and monitoring. And it's helpful in assessing the aortic valve, the anatomy, the severity, and it will give an evidence of the possible etiology for the regurg, in addition to assessing the size and function of the left ventricle. And it's important to assess the size and the function of the left ventricle because the decision to intervene in such patient will be highly dependent on the end diastolic and end systolic dimension of the LV, because the outcome will be affected if it reaches such a limit with no recovery. These in this table there are the classification of the aortic regurg as well as the echocardiographic signs of severe aortic regurg. The signs of severe AR that need an intervention, like a hollow diastolic flow reversal in the descending aorta, but most importantly is the large jet with the jet width of more than 65% of the LVOT, the left ventricular dilatation, specifically the end systolic dimension more than 50 millimeter or end diastolic dimension more than 65 millimeter. And there are the semi-quantitative measures for regurgitation, like vena contracta more than 6 or the pressure half time of less than 200. And the quantitative measures using the PISA to assess the AROA, if the effective regurgitant orifice area is more than 30 millimeter square or the regurgitant volume more than 60 ml, that indicates severe aortic regurg. Cardiac catheterization in case of aortic regurg usually as a preoperative assessment for coronary anatomy. And sometimes at the same time of coronary, there might be some assessment of the LVADB and assessment of ejection fraction. Last topic is the bicuspid aortic valve. The bicuspid aortic valve typically has a two cusp of unequal size with one large cusp that have a midline fibrosis or what's called a raphe, and representing an incomplete separation or congenital fusion of two cusps. It's affecting approximately around 1 to 2% of the general population, and it represents the most common cause of congenital aortic stenosis with regard to the calcified bicuspid aortic valve. The bicuspid valve usually predisposed to an accelerated calcification, and almost all patients with bicuspid aortic valve eventually will become stenotic. And the gradual calcification of the bicuspid valve result in significant stenosis, usually at the 5th or 6th decades of life. The abnormal architecture of the bicuspid valve, in addition to some risk factor like the in patient with tri-leaflet valve like atherosclerotic risk factor, all of which will induce the early degeneration and calcification of the valve. And due to the abnormal architecture, the turbulent flow will lead to injury of the leaflet, which lead to fibrosis and calcification. Less likely, patient will with bicuspid aortic valve will have purely valve incompetence, or will have complicated valve by infective endocarditis. And most of the time, patients with bicuspid valve will have some associated aortic root or ascending aorta dilatation. And the prevalence of aortic enlargement will increase with age. And it is considered one of the most important risk factors for aortic aneurysm and acute dissection, which is related to the underlying aortopathy and medial degeneration that will lead to hemodynamic derangement. Usually, it is related to the structural abnormalities of the microfibril within the aortic valve. That will lead to thinning and dilatation of the ascending aorta, which lead to aneurysm formation and dissection. The genetic factor has been studied, and there are several genes has been associated with bicuspid valve. Most important, the Notch1, which result in abnormal valve development. And other studies yet confirm the presence of familial association or clustering for bicuspid aortic valve and left ventricular outflow tract obstruction. The anatomy of the bicuspid aortic valve, it's usually involve an unequal cusp with raphe and smooth cusp margin, as we said earlier. Sometimes there will be two equal cusps, but most of the time will be one larger than the other. The raphe is represent a fibrous ridge at the site of fusion of the two conjoined cusps and is identifiable in most cases. And there is a wide spectrum of a bicuspid aortic valve, including either partial or complete leaflet fusion, the presence or absence of raphe or multiple raphe, as well as the orientation of the true commissure. With the most common form is the left and right coronary leaflet fusion, representing around 70 to 80% of patients with bicuspid aortic valve, followed by the right and non-coronary leaflet fusion in around 12% of bicuspid patients, and least for a common form is the left and non-coronary leaflet fusion. Most of the time, the coronary artery will arise in front of the cusp in which the raphe is present. This slide showing the classification, or what's called the severe classification for bicuspid aortic valve. And in this table, we can see three subcategories from that group. The first categorization is dividing the valve by the number of raphe. Type 0 with no raphe, and type 1 with 1 raphe present, type 2 with 2 raphe present. Then the subcategory with the spatial position of the cusp and the raphe. In type 1 will be only cusp because there is no raphe, but in type 0, sorry, but in type 1 and 2 there will be based on cusp and the raphe. With type 0, we can see either to be anteroposterior orientation or lateral orientation or left to right orientation. In type 1 subcategorization, we have 3 subcategories, either left to right or right none or none and left commissural fusion. And type 2 is only 1 subcategory, either right none or left right commissural non-fusion that was present. The second subcategory, it was based on the valvular function with either insufficiency, stenosis, or mixed pathology, and that was these numbers represent the population presented in that study. Other classification for bicuspid is based on the orientation of the raphe and the origin of the coronary arteries, which is the dichotomous classification, in which either the coronary cusp fusion or the mixed cusp fusion. The coronary cusp fusion, the up and the right, represent the fusion of right and left coronary cusp, while the mixed cusp fusion represent the left non-coronary or right non-coronary, and this will have a right-left relation of the raphe. This is showing the same, the severe classification with dichotomous classification of the bicuspid aortic valve with some echocardiographic images. The bicuspid aortic valve stenosis is almost 50% of aortic stenosis leading to aortic valve replacement in adult is related to bicuspid aortic valve. And the histopathology of the bicuspid aortic valve stenosis is similar to that of tricuspid valve stenosis with lipid deposition, new angiogenesis, and inflammatory cell infiltration. Both the atherosclerotic risk factor as well as the morphology of the leaflet play an important role in the progressive and early degeneration of the aortic valve and the development of stenosis. With the right and non-coronary leaflet fusion in children is associated with a higher percentage of stenosis, while in adult population, the fusion of right and left coronary cusp associated with more rapid aortic stenosis. The bicuspid aortic regurgitation usually isolated moderate to severe regurgitation. In case of bicuspid aortic valve is less common, with only about 10 to 10% of patients with bicuspid aortic valve. Mixed aortic stenosis and regurgitation is often present. And the population studies have shown that around 2 to 6% of patients with bicuspid aortic valve will undergo aortic valve replacement for severe aortic regurgitation during their lifetime follow-up. The mechanism by which aortic valve regurg will occur in bicuspid valve is almost the same as for those of tri-leaflet valve, with either abnormalities of the leaflet of prolapse, unequal leaflet size, the redundancy of one leaflet, leaflet thickening and immobility, endocarditis, aortic root and annular dilatation, which is common association with bicuspid aortic valve, aortic dissection, or post-valvoplasty for congenital aortic stenosis. The phenotype of aortic root, the dilatation of the aortic root, occurs in around 10% of bicuspid aortic valvopathy or orthopathy, and is often associated with a regurg. To diagnose the patient with bicuspid aortic valve, the transthoracic echo is the modality of choice. And usually the finding that is suggestive of a bicuspid valve in transthoracic echo, either systolic doming of the leaflet, eccentric valve closure, or leaflet redundancy. The eccentric valve closure is not always sensitive or specific, because even sometimes with tri-leaflet valve, there will be some sort of eccentric closure or eccentric jet. The presence of a raphe is one of the findings in case of bicuspid aortic valve. Elliptical orifice of the valve during the systole, and usually assessing the raphe or the elliptical orifice usually during the systole, because during Diastole, when the valve is closed, sometimes the RFA might be misinterpreted as a tri-leaflet valve. Dilated aortic root or ascending aorta, all patients with bicuspid aortic valve need to be evaluated for the dilatation of the root and the ascending aorta. When there is an unexplained aortic root dilatation is found, and bicuspid aortic valve is not excluded by transthoracic echo, transesophageal echo might be indicated to delineate more clearer images. Other modalities like cardiac CT or MRI may be useful in diagnosis or excluding the underlying pathology. And the CT and or MRI also recommended for evaluating the anatomy of the aortic root and the ascending aorta. This is all for my lecture. And if any comment or question from Dr. Nadir or the audience.
Thank you, Dr. Muhammad. Any question from the audience? Dr. Nadir.
Assalamu alaikum.
Alaikum salam.
Thank you, Muhammad, for the invitation. Excellent presentation. I have a few comments on the anatomical facts of the aortic root. We all know that aortic root anatomy is very vital for the cardiac surgeons. My first comment is on the aortic valve annulus. The aortic valve annulus is a virtual annulus. How is it related to the surgeon? The surgeon would wonder why a virtual annulus is important to me as a surgeon. So we all know the surgery which is called valve sparing root replacement. There are two techniques that are performed in valve sparing root replacement: the remodeling technique and the inclusion technique. The remodeling technique is Sir Jacob's technique, and the inclusion technique is David's procedure. If you have seen the David procedure being performed, there is a dissection that's carried out outside the aortic root. The aim of that dissection is to reach to the level of that virtual annulus, so which passes through the nadirs of the all leaflets, the three cusps of the aortic valve. And this is the relevance of the virtual annulus to the cardiac surgeons. Dissection outside until you reach that plane of the virtual annulus where you fix the graft in which you include the aortic root. That's why it's called an inclusion technique or David procedure, David 4 procedure. This is one comment. The other anatomical fact, which Dr. Babge already mentioned, is the subcommissural triangles. They sound like simple anatomical facts, but when you face a heavily calcified aortic valve, you should bear this anatomical relationships in mind. The commissure between the right and non-coronary cusp, if there is any calcification in that area that needs to be removed, it should be removed very carefully. Otherwise, you can easily avulse the membranous septum and create a VSD. It's very hard to repair. The subcommissural triangle between the left and non-coronary cusp. If heavily calcification in that triangle, if not dealt with vigilantly, can really can create an avulsion or a defect in the anterior mitral leaflet. The last comment is on anatomical fact related to posterior aortic root enlargement, is the presence of the fibrous trigone below the nadir of attachment of the non-coronary cusp. And you know that the Nix technique goes through this area. So there is a theoretical potential for creating a mitral valve insufficiency by performing a NIC procedure rather than Manugian procedure. Otherwise, I think very well presented, Muhammad Babge. Thank you very much.
Thank you, Dr. Nadir.
Thank you. Any question from the audience? Okay, we'll meet inshallah after 10 minutes at 15:15.
مدني. دي شكلها جود بلان، لكن ممكن تتغير طبعا حسب اللي
Dr. Hani?
Yeah, موجود. Should I start?
Yes, please. You can start changing.
Oh, yes. طيب السلام عليكم. My name is Hani Barnawi and I'm R1 from King Faisal Specialist Hospital and Research Center, Jeddah. I'm glad to present you the randomized endovein graft prospective trial, also known as regroup trial. Quick history. Despite the numerous evidence favoring the multiple arterial conduits, still the saphenous vein is the most commonly used conduit in CABG, with two main limitations. First of which is the patency rate, which is 60% at 10 years, and the other limitation is the site complication, such as infection and pain. For the endoscopic vein graft harvesting, it was first introduced in the mid-90s, and it is a minimally invasive technique designed to reduce the complication, the harvesting complication. To start with the study, what is the question asked in this article? Does the study test the stated hypothesis? The question was to assess the clinical outcome of the open versus endoscopic vein graft harvesting in CABG surgery in a multi-center randomized trial. For the PICO, the P are the patients undergoing elective or urgent CABG with cardiopulmonary bypass and cardioplegic arrest, and a decision to use at least one vein graft underwent screening for enrollment. For the I is the endoscopic vein harvesting. The comparison is the open vein harvesting. The outcome, the primary endpoint is the impact of the saphenous vein grafting technique on the rate of MACE, which is the composite endpoint of all-cause mortality, non-fatal MI, and repeat revascularization over the active follow-up period of the study, post-operative. So the primary hypothesis was that a significantly smaller proportion of CABG subjects with vein graft harvested by open technique will experience a MACE event compared to CABG subjects who underwent the endoscopic during the follow-up period. So was it significant? What's its significance? It saves lives and saves money, also saves time, cost effective and relative to the practice. They thought that this trial will fill a significant gap in the existing knowledge regarding whether to go endoscopic versus open vein harvesting in CABG. Are there any conflicts of interest? They listed about 16 participants and funders and investigators. One of which was the Bilboy publication, Medscape Cardiology, WebMD, and so on. Apart from the 16 participants participating sites and funders, the author have no other funding, financial relationships, or conflicts of interest to disclose. The design of the study was a randomized controlled trial parallel with an open label. The primary purpose was the treatment. The total number of enrollees was 1,150. The median duration of follow-up was 4.7 years. The mean age was 66 years. the percentage was 0.5% of female, and the percentage with diabetes about 49%. For the inclusion criteria, the inclusion was an age of 18 years or above, planned elective or urgent but not emergency CABG with the use of the median sternotomy approach, planned to use at least one saphenous vein graft as a conduit, and experienced endoscopic versus open harvester available for procedure. For the experienced, there was three objectives to be to fulfill. The first is not less than 100 open or endoscopic vein harvesting cases. For the endoscopic vein harvesting, the conversion rate to open should not exceed 5% and no less than 2 years experience. For the exclusion criteria, a planned valve procedure in combination with CABG, the presence of moderate or severe valve disease, the presence of hemodynamic instability or cardiogenic shock, enrollment in another therapeutic or interventional study. Planned off-pump CABG, life expectancy of less than 1 year, a history of venous stripping or ligation in the leg. Last but not least, is in the inability to provide informed consent. Regarding the follow-up, an assessment occurred at the baseline, intraoperative and post-operative, also at discharge or 30 days if the patient is still hospitalized. At 6 weeks and every 3 months thereafter until the end of the active follow-up phase. After that, an intermediate term MACE outcomes were collected passively for an additional 2 years. What and how variables were measured? The variables were all-cause mortality, non-fatal myocardial infarction, or repeat revascularization over the active follow-up phase. How were they measured? Using the Kaplan-Meier analysis, which was used to estimate the survival. Also, a log rank statistic used to test the quality of the survival function in the two groups, and the Cox proportional hazards model used to investigate the effect of harvesting technique on the time until the MACE outcome. What potential co-founding factors? There is this, age, sex, and harvester's experience. For the data collection, there were 3,394 patients who underwent an assessment for eligibility. Only 1,188 gave their consent. After further assessment, 1,150 only underwent the randomization, leaving 574 who were included in the analysis for the open vein graft, and 576 who were included in the endoscopic vein harvesting. These are the baseline characteristics for both groups. As for the age, and which is 66.4 for the two groups. Also, the other characteristic of surgical procedures, as you can see, most of the cases were elective, for 423 in the open versus 415 in the endoscopic. For the endoscopic harvesting conversion to open, there were 32 cases who went from endoscopic to open harvesting. The causes were mainly either due to bleeding, unacceptable duration of endoscopic procedure, insufficient amount of usable vein from endoscopic procedure, harvesting, unable to locate the harvester was unable to locate the vein. So as you can see here is the survival results. They estimated it with a hazard ratio of 1.12. The p-value was 0.47, which is non-significant. For the primary outcome, which is death, myocardial infarction, or repeat revascularization, occurred only in 13.9% of the endoscopic vein graft group versus 15% in the open vein graft, with a p-value of 0.47, which is not significant. Also, the individual component of the composite outcome was similar between the treatment groups. A follow-up study, a 2-year study, which is the intermediate follow-up study, also further assessed the composite of death, myocardial infarction, and repeat revascularization for another 2 years. As you can see in the survival graph here, it also shows no much of a difference between the two. During the entire follow-up, the primary outcome, which is the MACE, occurred in 21.9% in the endoscopic group compared with the 23.5% in the open group, with a p-value of 0.52. And the death from any cause occurred also in 12% in the endoscopic vein group versus 13.2% in the open group, with a p-value of 0.52. The non-fatal MI occurred in 37 patients, 6.4% in the endoscopic versus 7.3% in the open group. For the repeat revascularization, also occurred in 7.8% in the endoscopic group versus 9.8% in the open group. An adjusted multivariable Cox regression model found no significant difference in MACE risk between the two groups. Among male patients undergoing CABG with one or more saphenous vein bypass graft, major adverse cardiac events were similar between the endoscopic vein graft and the open vein graft harvest. There was no difference in major adverse cardiac event with the long-term follow-up. The endoscopic vein graft harvest was associated with marginally fewer leg infections. Therefore, this harvest technique may be considered preferential. For the discussion, this randomized clinical trial found that there was no significant difference in MACE occurrence among patients who underwent the endoscopic versus the open harvesting technique for the CABG over a median follow-up of 4.7 years, as mentioned before. The saphenous vein is the most common supplementary conduit for CABG, but concerns have been raised about the long-term ischemic events when the endoscopic harvesting technique is used. The uncertainty has translated into variable adoption rate because of the difference in the establishment of the endoscopic technique, as in North America, which is more than 80% of the patients, versus in Europe, less than 50% of the patients. For the intermediate term results, the follow-up 2 years assessment of the regroup are reassuring and demonstrate no significant difference in the cardiovascular events between the endoscopic versus the open technique. However, the leg wound complications were reduced with the endoscopic technique. Limitation of this study include the lack of imaging evaluation of graft patency, as there were no angiographic assessments, but their their discussion was even though there was no angiographic assessment, it would appear for the other complications such as repeated revascularization, non-fatal MI, or the mortality. And the use of only expert harvesters, as mentioned before. These results provide strong reassurance that the endoscopic technique is safe up to 4.7 years after the procedure. They still a 10-year follow-up study is planned regarding this regroup trial. These are my references, and thank you for listening. Any comment?
Thank you, Dr. Hani. Any question? Any questions from the audience? Thank you all. So by that, we conclude our sessions for today. Thank you.